Thank you very much, Melanie. It's great to be here again. I love coming to Brisbane. I was saying to Mal earlier that the centre of gravity for ethical debate has shifted slowly north. Years ago, Melbourne was the hotbed, and briefly Sydney, but really now, if you want to have a serious debate about ethics and health law, you really need to come to Brisbane, and I congratulate everybody on that, and QUT in particular for its contribution, particularly in end-of-life settings, which has been a lot of the data that we're building our future information on is coming from right here, so it's very, very exciting to be here. It's also nice to come and be back in summer again. I understand it's midwinter, but the Brisbane didn't get the memo. Unless it's always like this. Is it always like this? Is it?
No, it's hot.
All right, well, with a bit of to and fro with Melanie, and I thank Melanie for inviting me to come up and the AMA for sponsoring. I actually talked at their national meeting recently on similar subjects, so they are genuinely interested in this. After some correspondence with Melanie, we decided to call it very broadly Dying in the 21st Century. So this is meant to be quite a broad-ranging discussion. And I'm hoping with the panel having such a wide range of interests that this will essentially bring in anybody from any background. My own interest is in intensive care, but that doesn't mean to say that's all I really want to talk about. This is what I am going to say, which is breaking my talk up into 4 little chunks, basically. The first is my usual whinge, which I'll try and compress down to the shortest possible, but basically dying isn't going too well in the 21st century so far. My second bit is going to be about, very briefly, why things aren't going to get any better unless we do something. Third bit is that we do have some tools, but they're very deficient ones. They're not going to work in their current form. And the fourth is really the opportunity to open this up and start talking about, now what? So what do we do? The first thing I want to say is that while dying isn't going too well in the 21st century in Australia, living has never gone better. And if anybody wants to puddle around on this website, you will have the best possible time. It's called mortalitytrends.org. It's a UK website. But what this graph shows is the plummeting death rate in the preventable deaths, which is the age group 35 to 69. These are preventable deaths, and this is preventability of death happening in Australia widely since in the 1970s. We have done better than any country on the planet and now are the world leaders in preventing premature death. So congratulations to the Australian health system, and the whinges that I'm about to go through should not be seen to detract from the enormously positive effect that acute medicine in particular has had. Because this is beyond the era of public health changes. This is actually the medical enterprise which has dropped death rates so profoundly as this. This isn't just clean water. This is hospitals. So that's gone really well. But, of course, with every silver lining has a cloud, and the cloud here is that, of course, now we have this major ageing demographic. All those people whose deaths were deferred still have to die. They're just going to do it at a much older age. And the fact of that older age has an enormous impact on how that dying process then proceeds. And this is really a demographic shift that everybody keeps talking about, but at the front edge of it's actually already here. So this isn't a future threat. This is a current reality for those working in acute care settings. There's a demographic shift of the age group of people going to hospital and the nature of the illnesses that they go to hospital with. And this storm that's potentially building threatens to overwhelm the system that's been set up to deal with quite different forms of illness. In particular, using this admittedly rather simplistic graphic that's very widely quoted, what you clearly see is that the sudden death is the preventable deaths that we've done so well with. That's what we've managed to eradicate. These were deaths from things like pneumonia and so on. That top layer disappears somewhat. By the time you reach 80, you're going to really die of organ failure or frailty. That's the kind of process that we're seeing. For instance, cancer is not a leading cause of death once you're over 80. It drops down to only about 10%. Most people are dying of dementia, organ failures, and so on, increasing frailty. A major challenge for an acute care system. This was quite an important paper from Western Australia, which I thought was so gobsmacking. We reproduced it in Newcastle because we just didn't believe it. But they said that people dying had 8 admissions to hospital in their last year of life, 2 ED visits that didn't result in admission, and a 60 or 70% chance of dying in an acute care hospital. We found that very hard to believe. We reproduced it in Newcastle. It turns out to be exactly the same there. And I think you may want to look at that in a Queensland context as well, because if that's true here as well, we really are facing a major demographic issue. The bottom line that everybody now says, this seems to be now a generally accepted fact, that most deaths now occur in acute care hospitals, and locally where I work, private hospitals have also taken on quite a burden of dealing with dying as well. So again, you might want to look at that in a Queensland context, but about 20% of cancer deaths now occur in private hospitals in Australia as well. This seems to be not uniquely Australian. This is data from Ireland, which seems to, for some reason, have kept place of death data since 1885, which is quite impressive. But what they've shown is that those two things crossed over when I was a kid and seemed to be just moving ever further apart. And the projections for the future are for these things to continue to drift in that direction. As things stand at the moment on the campus I work on at John Hunter, 1 in 4 deaths that occur on that campus occur in the intensive care unit. Of the remainder, about 1 in 3 are mediated by what's called a rapid response team, or what used to be a MET team. We go to the ward and a decision is made. In a cancer hospital that I also work in at the moment, 2 out of 3 MET calls result in a end-of-life decision. So intensive care has muscled its way, one way or another, into being big players in all of this, which of course is gobsmackingly expensive as well. And I don't want to make the economic argument strongly tonight, but there is an economic issue at stake here, which is why I think we're getting so much government buy-in just at the moment. And I don't want to make that the major issue, but you have to recognise, this is New South Wales data, that the major costs of end-of-life care occur in the last 30 days. It's actually that final battle to prolong life, that final inch, which is costing all the money, and somebody's going to have to wake up to the notion that some of this is futile money spent. Trauma is particularly big, and we see a lot of very futile trauma treatment being done for symbolic reason in hospital. This is the sort of thing that we really have to look at. More importantly, from an ethical viewpoint, acute care doesn't appear to be the preferred place of death. If you actually do survey work, which almost everybody has done, around 70% of people say they'd like to die at home, which is, of course, as far from the truth as possible at this point. And more, perhaps even more damningly, acute care actually doesn't manage, so as the default place of death, you'd hope it would be managed well, but in fact, acute care manages death extremely badly, and this is something which I think is perhaps the major substance of what I would like to say for the next couple of minutes. This is a quote from Cicely Saunders, who was very good at these one-liners. How we die remains in the memories of those who live on, and this is having an enormous impact on opinion in Australia at the moment. And you're probably aware that Australia has about the highest support for euthanasia of any country on earth, other than Japan, interestingly. And there was a piece of research presented at the recent ARBL meeting in Sydney from, I think, Auckland, where they were able to track people's enthusiasm for euthanasia entirely to whether they'd experienced a bad experience of dying in their own family. And this seemed to drive a desire for euthanasia, and if they didn't have that experience, that had a good experience of dying, they didn't favour euthanasia. So it appears to me as though the widespread groundswell of enthusiasm for euthanasia could well be resulting from bad experiences of dying that are being passed on from generation to generation. So I think we're fueling the fire here of what is a partial but probably not particularly good solution to our problem. We can talk more about what you think about that. This was an audit published, done by Paul Komisarov and others from Melbourne, but you know, what's the basic information we have about dying in acute care? Well, it's not very encouraging, because this was, I think, at Monash, no discussion of end of life until the last 24 hours in 2 out of 3 people who died in an acute care setting. It's very hard to have a good quality system if nobody talks about it until it's happened, basically. There are very little documentation of anybody's preferences, and that this is from a note audit, so there was documented in the patient's notes unresolved conflict at the time of death in 1/3 of the patients who died. This is a pretty terrible proposition. You can see how this might revisit itself on subsequent deaths in the same family. We did an audit, which we're just trying to get published at the moment, where we looked at 100 consecutive deaths on wards in Newcastle. What's interesting is that 85% of the deaths were medical. That surgeons don't have a huge lot of deaths. It's really medical patients who die. Of those 100 deaths, 20 had no mention that they were dying at all. They sort of washed up in the mortuary with nobody having actually mentioned that they were dying at any point. 1 in 10 only had a no CPR order, which is obviously being over-translated as a palliative care order. SAGO is the standardised adult general observation chart, which is a New South Wales-wide observation chart. They were continuing to have their blood pressure and things taken at the time of death, which you'd wonder what the hell the point of that was. Very few of them had a palliative care referral, and I think I'd like to talk more about palliative care and its role in all of this at some point. Only 1 in 10 were having pain scores done at the time of death, even though the majority were still having their respiratory rate, oxygen saturations, blood pressure and heart rate monitored at the time they died, which doesn't represent a structured or strategic approach to end-of-life management. Care of the dying is what I prefer to call it. And this is the sort of take-home, essentially, of this bit of the talk, which is that acute care functions on a series of defaults. Ken Hillman calls this a conveyor belt, but what they are is defaults. You default to treatment. This is what happens when you come through ED, and the defaults all start to happen. And they work really well. If you come in with chest pain, all the defaults are good. You get some aspirin, you get an angio, you get stented, you get cured. Fantastic, it's all good. The defaults in place for end of life are neither effective, evidence-based, nor cost-effective, and as defaults go, they're absolute rubbish. Which led one commentator in the BMJ, and I love this phrase, death in acute care is akin to an industrial accident, which is certainly how it feels sometimes when you're out there on the wards. And the great philosopher of the 20th century has a ready explanation as to why this might be, which is this failure is just really the result of a failure to prepare. It isn't actually a anticipated outcome of acute care admission. And this is what I phrase the 60%, 1% problem, because while 60% of us, that's all bar the first 3 rows here, are going to die in an acute care setting, for an acute care hospital, death is only a low incidence event in terms of their turnover of patients. So for the general wards or most units, particularly surgical units, death is actually quite unusual. And when we looked at our figures, and again, it's something you might want to look at yourselves, only about 1% of the people who came through that front doorway actually ended up dying. So you can see that the pressure hasn't been there for them to set up default systems that anticipate that might be an outcome of treatment. My second point, things aren't going to improve spontaneously. In fact, the projections from the UK is a relative 40% increase in dying in hospital. Even though they're doing their absolute best to combat that, they still think that's what's going to happen there. And part of the reason for that is not just the demographic shift, but that graph that I showed you that showed how dramatically successful we'd been about postponing death or saving life or whatever you want to call it. I call it postponing death. I think saving life's a joke expression, but has produced rising expectations from the general public about what we're going to do. And for me, the pivotal moment was when you could no longer write old age on a death certificate. And I don't know, Mal might remember whether that was ever possible in Australia, but in England you could write died of old age, and now they have to die of pneumonia, so everybody does. The problem with that is that every cause of death, and this is another quote from the BMJ, can be resisted, postponed, or avoided. So as soon as you have to die of something, then there has to be the possibility that you didn't need to die of it. And this is all part of a notional rising expectation that will keep curing people indefinitely. The other thing is this very loose concept of the rise of patient autonomy, or more broadly, respect for patient autonomy. But really, in this context, what this has been translated into is a sort of consumerist approach. And I looked at a year's worth of complaints about end-of-life care in New South Wales, and overwhelmingly they were about not doing enough. It's very interesting because we see egregious over-treatment as being a major issue, but in fact the complaints are all, we're not doing enough. So there is the danger that there may be some sort of consumerist, probably rather ill-informed drive towards doing more and more that isn't being driven by us, the intensivists or whoever, but is actually generally coming from the general public and the families in particular, the children in particular of elderly people. And I should cite one bit of research that Charlie Cork did in Geelong, where he gave a scenario to elderly people in a nursing home of having had a stroke and becoming unconscious and developing aspiration pneumonia. Would you want intensive care? And they all said no. in my view, quite rightly. They gave the same question to their children. If this happened to you, what would you want? And they all said no. And then they said, but if it happened to your parents, what would you want? And 100% of them said they wanted their parents ventilated in intensive care. Children make rubbish surrogates. They are being given the responsibility of making these decisions for their parents. And what we know is they're just driving a consumer-led drive towards bad medicine, which I think is something that we all have to take very seriously. And, again, I hope we have some discussion about that notion too. What my angle on it all is, as an intensive care specialist, and Jeff Lippman's here and no doubt has exactly the same experience, which is that we get involved in these decisions that have to be then made. You know, all end of life now is a managed event. Decisions has to be made. We have to stop. We have to not start. This is now the modern world, unprecedented in history. But now this is how end of life proceeds. So I've had to do this something like 4,000 or 5,000 times now, sort of debate about end of life issues. And this is where the tools that we have are very deficient. It's where you're trying to make these difficult decisions, the hard choices at end of life, that the tools that we are being given or have available to us just don't work. They don't completely work. I've got to say this carefully because Colleen will kill me, but the tools that we have they're not joined up, the dots aren't joined, and just at the moment, I can't say that any of this is really functioning, even though potentially it could. This very obscure committee, and I must confess I'd never heard of this committee until they produced this document, and that's an ethical principal. That's not a misspelling. It's a principal committee, a primary committee. Produced an overarching statement about advanced care directives, which the ethical section of which I thought was really good, actually, I have to say. And this whole notion about planning in advance has been promoted as being a solution to the dilemmas that we currently face. This is a quote from quite a prominent Canadian researcher called Darren Hayland, who said that this is quite a bold statement in my view. Advanced care planning, this is ACP is advanced care planning. Perhaps the single most important thing we can do as a society and as stewards of our health care system. So he's looking at the cost issue at stake here as well. And to improve the quality of care anyway, advanced care planning is meant to do all that lot. Maybe. The alternative view is the H.L. Mencken quote, which is, there's an easy solution to every human problem, neat, plausible and wrong. You have to be a bit cautious because there have been endless occasions where advanced care planning hasn't had that effect. So we just have to look at that a little bit critically. One of the components of that would be a written directive. This is the notion of the instructional directive. Now in Queensland this is called an advanced health directive. So this is a document composed by a patient addressed to potential treating teams of the future. So it's a very hypothetical document. Now these may be highly influential in any context, but you just have to bear in mind where some of the downsides of all this really reside. These are very lopsided. You can't demand, you can only refuse, which hasn't pleased everyone, I have to say. They remain rare. I don't think that they've become substantially more common except in residential aged care, where I think they have definitely caught hold. But as a general community thing, they're still not common. They're unavailable. We audited our first sighting of an advanced care directive at our hospital, and it was on average 3 days after the patient was admitted, which didn't give you time to really react to it. They're generally not sought. There are no hospital processes whereby if you get admitted tomorrow to an acute care hospital, somebody's going to say, where's your advanced care directive? They don't have anywhere to put it. Nobody knows what to do with it. You could photocopy it and put it in correspondence, which is what happens in our hospital. But exactly how that works, I have no idea. Nobody asked for them, and they're not documented in an acute care setting. And contestable. Now, in New South Wales, they're contestable under common law. In Queensland, they're contestable by legislation. So if the doctor disagrees with it, they just ride roughshod over it. Is that right?
Not quite.
Well, we'll debate that, but that's the way I read the Queensland legislation. I know Lindy's here somewhere. She'll perhaps put us right on that.
It's the definition of good medical practice, and it has two components, clinical and ethical.
Okay, so good medical practice continues to be a potential override for these. The big dilemma, and I'd again love to hear more about discussion on this question, is if you write something to your hypothetical doctors of the future, what is it you should write? Because you've got two broad choices. One is you could talk about your goals. This would be a free text notion. You'd write something about, this is the kind of life I value, this is the sort of thing that I would not want to live if I lost that capacity. And then it would be up to whoever looked after you to interpret what that meant in terms of the technology available at that moment in that setting. So that's one option. The second option is you could list a whole load of interventions that you may or may not want and tick or cross whether or not you do at this moment or wouldn't want those at some point in the future. You see there's a distinction there. The advantage of the first, the advantage of that is that's a highly transportable notion. In other words, you could have that in the community, you could have that in acute care settings, you could have that essentially anywhere, and everybody would be able to make use of that notion. The advantage of that is that in an intensive care setting or an acute care setting, that's quite intelligible to us. So we haven't decided in New South Wales which way to go on this. We have no idea which way we should be promoting it. It gives you some idea of how much in its infancy this whole idea really still is. The alternative is guardianship. And the guardianship experiment on East Coast Australia is unique in the world, as you may know. And maybe you don't. Maybe you think this happens everywhere, but it doesn't. This idea that everybody has a default layperson who makes decisions for them if they can't make their own decisions is actually very unusual. It only exists in Belgium outside Australia. But I do think there's a savage irony in the guardianship notion, which is that they're defending the autonomy of the patient by actually removing it and getting somebody else to make decisions for you, which I think is very ironic. And if we've got time, I just want to do a little exercise with you, because this is the point at which everybody will go into a coma otherwise. Okay, this is the scoop, and I put this on the AMA invited me to put this on a blog, actually, so whatever the AMA blog is, this anecdote is on there. You imagine you're in a restaurant, and you get a phone call from your partner, or a text, saying, I'm going to be 10 minutes late, can you order for me? Okay? And this is what you know about your partner. He or she is very fond of bacon double cheeseburgers, is somewhat overweight, and has a high cholesterol. Okay? So this is your choices. You could act in her or his or her best interests by ordering a green salad. You can imagine how popular that's going to be. Or you could go for it and make a substituted judgment as to which, give her what you think she would ask for herself. So now this is where we test who's a libertarian and who's a fascist. Who would vote for the green salad? Okay. And who would vote for the bacon double cheeseburger? The libertarians win the day. But now here's your exercise. That wasn't your exercise. This is your exercise. Your exercise is this. What I want you to do is turn to the person next to you and come up with 3 alternatives to either of those. 3 alternatives to doing either of those things. I can see you've all got some. I guess what I'm saying is that guardianship, either making a best interest judgment or a substituted judgment, isn't the only possibility. There are some other alternatives out there that I think we should be looking at. These are ones that I came up with. You could have seen the menu and chosen in advance before you even left home. Say, look, if I'm late, get me this. That's a possibility. You could ask your partner who she would like to choose for her, instead of saying, well, rather than asking me, why don't you get your sister or your best friend to choose, because they might be better to do so. Get her to pass the phone to somebody in the car and get them to read out the menu and get her to choose. And these things actually have parallels in the end-of-life setting, because to have seen the menu in advance and chosen something as an advanced, but who the hell thinks of doing that? That's why it's rare. It just isn't going to. You'd have to know you're going to be late for the restaurant, and where you were going, and it's just very difficult to really envisage it. Asking your partner who she'd like to, that's choosing a substitute decision maker. You've got more chance if you choose your best friend than if you choose your husband. I've been in this situation, trust me. I got into terrible trouble. You could pass the phone to somebody else in the car and get them to read out the menu. Which is supported. This is important. Her lack of capacity is our problem, not hers. We have to come up with a solution, and this is the supported decision-making idea, which some jurisdictions have picked up, not Queensland, but South Australia and Victoria are looking at this now. So here we go to the now what, and this is the lead into having a sort of panel discussion about all of this lot. And these are my now whats, and you're welcome to bring your own now whats. But the first thing is that we need a terminological shake-up here, where us and the palliative care people and anybody interested in end of life get their act together and actually start using the same language. Because we all need to know what we mean by end of life, and it isn't the same as care of the dying. I think once you've reached care of the dying, that's actually a separate notion to end of life. I think end of life is a much broader concept and actually is the terminal phase of the illness which you have probably had for quite some time, but you may not survive beyond the next 6 months or so. So I think that's one thing that we have to do. And the surprise question has stood the test of time as being one way of introducing that idea more broadly. I don't know of any hospital that's doing this. I don't even know in Australia of general practice doing this, although in England they do, and this could be an important thing. Care of the dying is a separate notion. And I think we do that badly too, which is horrifying. A lot of people ended up being sucked in by the Liverpool care pathway. I don't know, are you familiar with the Liverpool care pathway? This is the care of the dying strategy that took off in the UK and has been very broadly. I recommend this report, which has only just come out. If you Google the independent review of the Liverpool care pathway, what you'll discover is a damning report. Pathways are bad, they're tick box exercises, and they don't really work, and that's what this says. And we've not gone with that in Newcastle. What we've been doing is, and some people here are quite interested in what we're currently doing, which is to change the normal observation chart. In a subversive move, you just swap one observation chart for another observation chart, but the subtle swap has an observation chart that doesn't have your pulse, blood pressure and saturations on it, but has parameters related to end-of-life care. And the triggers are not of teams of people from intensive care, but people from palliative care who would then go to see the patient instead. So it's a subversive move, and we're just trialling it at the moment. So it's got quite, it's a double-page thing. For those who don't know our usual observation chart, you'd need to be told this looks exactly like a normal observation chart until you start looking at it. Supported decision-making, I mentioned. This is, I think, a South Australian one, but you can see that supported decision-making is part of a stepped approach that we're not currently embracing but should be. This is the join the dots concept. As an intensivist, I had to learn this notion of the chain of survival, that in other words, that it wouldn't all work unless everything worked. And that the links between what you did were as important as what you did. So if what you did didn't link with the next thing, then you're wasting your time. There's no point in being in a field doing CPR endlessly if there's nobody else if you can't move them. So I came up with something similar which has been adopted by New South Wales Health, which is, I call it the chain of dying safely, which is a term that Ken Hillman introduced into the lexicon, the notion that you have to die safely. And you can see that much of that takes place before you get to hospital. So, for instance, health literacy is not something that we can do much about. There needs to be a literacy around death and dying. I must say Sarah's book is an enormous step in the direction of making people literate around the notion of dying and what a good death might be and why that's important. Advanced care planning has its role, but it would be an out-of-hospital role, largely, and general practice, unfortunately, has not picked this issue up. Certainly not in Newcastle, where we did focus groups for a year, and I described the GPs as constructively negative. That's to say they weren't interested in doing it, but they were very happy to tell us why not. That we need a documentation focus in acute care setting so that we can make intelligible documents that are usable in acute care. We need palliative care to be integrated, and I'll say a little bit more about that, and then we have to honour people's choices and be audited and evaluated on having done so. So the system changes we could look at, well, we could look at changing the law. My own view on this is, and I would love to have more discussion about it, my own view is the law is an ass. No, I don't know about that, but the law is not having a huge impact on end-of-life care. Even in states where they're driving this very hard, like South Australia, it's not having a lot of buy-in. And when they introduced a refusal of treatment certificate in Victoria, it had very little uptake. Julian Gardner only saw 20 in a year. So these things are not running off the shelves in a big way. The health system has a lot more potential for invoking change, because it is the health system. And this is what they've just released in New South Wales. This was at the ARBL meeting. The Minister of Health turned up and released this document, which focuses very strongly on advanced planning. So you can see that that's where New South Wales Health, at least, is putting its money. Documentation is really important, in my view, and one of the things that we're looking at is to standardise documentation in the way that Queensland has done. When you come into hospital, to have a document which will be intelligible in an acute care setting and form some sort of medical order. And those who've seen the Queensland document will realise that this New South Wales thing plagiarises relentlessly the Queensland version, and I apologise for that. I thank the people who are doubtless here who drafted this document for us to pinch. The community is really where it's all at. But one of the problems is that the health system, in terms of it being a state health department, has very little community outreach. I don't know whether it's true here, but for instance, New South Wales Health, while it runs acute care hospitals, has almost no outreach into the community at large. So that's a major problem for the health system to actually do something for the community. Really, the federal government and the community itself really would have to drive that. So if they don't want this, they need to say so. Palliative care has to abandon the hospice. I'll talk more about that, but I went to Palliative Care Australia's national conference and told them they'd failed, which wasn't very popular. But the hospice movement was a radical critique of medicine. But what had ended up happening was palliative care itself became subsumed under the very medicine that it was supposed to be a critique of. And we need to revive the critique. We need palliative care to get on the front foot here and actually integrate palliative care into the whole of medicine and lead the charge away from the medicalisation of dying, which to this point they haven't done. This is a piece of research done by the Health Roundtable, and it shows the in-reach of palliative care is very variable across. This is Australasia. These are code names for hospitals. But the name of the John Hunter is Tornado, and there's Tornado there. And we have a 0% referral of palliative care, despite the fact we get half the deaths in the Lower Hunter occurring in our hospital. There are no palliative care services there at all. So it gives you some idea of why I've got a biased view of how much in-reach palliative care have. This is a diagram that comes from palliative care literature, but they need to walk the walk. This is the talk. Now we have to walk the walk. Currently, palliative care is fitting in here somewhere, and that isn't where it belongs. And again, hopefully we'll have some discussion about that. I think that the personal issue is the big one, which is that we're just surveying our medical students for thanatophobia at the moment. There is a 7-point thanatophobia scale that you can be graded on, and I think fear of death among all of us is driving fear of death in the system, and until we confront that for ourselves, we're going to have a mighty struggle changing the culture of those around us. I think we're part of the problem, we're not part of the solution. So this is the takeaway from me. Improving end-of-life care is a win-win, so I think I'm not ignoring the economic argument here. It's possible to have a better system and a cheaper system at the same time, and there are very few medical things that you can say that about. Early discussions make better decisions. That's a thesis, but I think I'm right. Advanced care planning is part of the solution, but it doesn't work without the links. Current legislation does need review, but reviewing it won't solve your problem. We need to set standards, and the standard-setting people are starting to look at this. So you probably already know that the healthcare standards people are circling around end-of-life standards, and dying safely is a system of care. So the take-home message is that none of it works unless all of it works, and that the dog and the man really do have to work together. Otherwise we're going to be having the sheep all over the bloody place. Thank you very much.
So I might just get our panel members to come forward. And
so I'll do this from there. Yeah. Okay.
We can probably hear okay. Can people hear me all right without the microphone? The panel are happy with this speaker.
on the list have voices that shatter glass.
So Melanie's asked me to sort of facilitate this discussion. So I'll take comments from the floor and try and get the panel to pick up on them.
Thank you. That was also just lots of curious knowledge. You raised two good points, and I have two follow-up questions for that. The first one was that you obviously at some point need to make a decision about whether a patient that's been referred to is actually looking for intensive care as opposed to is in end-of-life phase. I want to know what the science out of that prognostication is at the moment and what you see happening, because that really is a decision that's going to critically affect whether or not the three of us or four of us that end up in intensive care should really be there. The second thing I want to ask is that having made this decision for a family member, I want to understand if you did get to this utopia where we have a perfect system somehow objectively saying, of the four of us, you're the three that will survive this intensive care experience and you're the one that won't. How do you go in and actually with the patient's family manage at that point the perception that you're giving up? Because as you said, the earlier you make that decision, the more scope you actually have to impact the quality of the day. But at the same time, the bigger the perception that you're giving up, whether that's the perception or whatever interpretation the family or the person themselves take. I mean, from my perspective, I'll share about the scenario. There was a patient with a terminal cancer where some people with treatment live 2 years, some, like the family member I have, lived 3 months. And you're in a position now of making that discussion and having that decision. I'm ready to, from the palliative perspective and from the intensive care perspective. How do you see that happening?
Yeah, well, I'll just reframe it slightly because the two things you've asked are actually part of the same issue, which is this notion of futility. So in other words, what you're saying is, when do we decide that it's a futile thing to do major surgery and put them on a ventilator in the intensive care unit? Now, what's the family's involvement in that process? I'll give you my own take, and then this would be a great one to put to others. Futility. Systematically, the New South Wales Health Department guidelines explicitly don't mention the word futility. And we've explicitly said that we aren't going to use that expression because we don't know what it means. I think that's a bit of a cop-out, to be absolutely honest, because I think futility is a really crucial notion. I mean, you can rename it, you can call it inappropriate treatment, you can call it what you like, but at some point you have to say, this isn't going to work. So we have to make a decision to not do it or to stop doing it. And we have to take some responsibility, and the family may have some share in that. So my own take on this is this, and Jenny and I were talking about this with Sarah beforehand. If you can't define a term, you don't necessarily have to abandon that term. You just have to come up with a process. So what I'm saying is there's probably a process for doing the decision-making that you're talking about that is a fair process, a reproducible, transparent, reasonable process to come up with a reasonable decision about what to do. You can't be certain of it, but you can be certain that you're doing the right process. And whereas the medical role in that is a joint role, and this is what we're trying to... A surgeon doesn't make the decision, an intensivist doesn't make the decision, but there should be some discussion. And Dominic Wilkinson's very interested in what happens when there is no agreement between the different clinicians involved. And then there's the family's role, and what exactly is that? But they do have a role. They have a definitely legally supported role in Australia. That's the unique notion of our guardianship system. So you can't do it without them. It's not like we just make the decisions and just do it all. So I think there's a two-step issue. One is a consensus decision among the clinicians as to what to do, and then there's how you take that to the family and how you then see the role of the family in contributing to that decision. And my own take on that is the family has the right of appeal against your decision, but they don't have the right to make claims for treatment that isn't reasonable. I mean, they can make claims, but they can't legally push such claims, so they're not really a right. But they do have a right to appeal against it, and the Supreme Court has really underlined that in recent times. So you just have to be very aware of that when you go to talk to families, is you are making a recommendation, but you do recognise that they have a right of appeal against that decision. So I'd just be interested in how they have to shout.
Interesting that you're using our advanced care, the acute resuscitation plan from Queensland, because in fact there's some errors in law on the document, which we discussed quite recently. And I put my hand up, I was there for as part of the whole planning of it. But in it states specifically that you do have to have consent to withhold treatment from a competent person, and this is playing out badly in Queensland because a lot of doctors think you do actually have to have that consent. To answer that young man's question about how do the family and the doctors play in, it's hard when the doctors don't understand the law, and I think Lindy and Ben have demonstrated that pretty well. But for us, it's making that decision and then finding the people who will understand that decision. And it's interesting that you think that research showed that families are pushing inappropriate decisions. I think that's families who complain are pushing
Yes.
inappropriate decisions.
Yes.
Whereas in fact, if you understand the complex interplay in families, when you start having that discussion, you'll pick the person who's going to make the silly decisions. And I think doctors are not very good at making those judgment calls. We just default back to treatment. It's very hard for us to put our opinion forward. When in a lot of those decisions, there's no right answer. You won't ever know. The patient may have survived, or it might have been a terrible death. You just don't know.
So does anybody else, I'll come to you, Jeff, but anybody else on
Yeah,
that?
because I'm just really concerned about your comment that you don't need consent from a competent person to withhold treatment, because our understanding of the law is that you do. You don't need to offer treatment, which absolutely will be of no benefit. You don't need to offer that. But to withhold life-sustaining medical treatment in the Queensland legal system, you have to have consent.
From a competent person, I'm not under any obligation to offer treatment that I don't think a person should have.
No, but if you are wanting to withhold life-sustaining medical treatment from someone who could potentially benefit from that.
Specifically, this comes down to CPR. And if I decide, and this is me being theoretical, I decide that CPR is the wrong thing to do for you, do I have to offer you CPR? Do I have to do CPR on you? If you say yes, and I say, well, it's not going to do it. It's a waste of time.
Do we have a clarification from the audience? I mean, my understanding is that Colleen's right and that the Mrs. Wu business and the coroner's decision around that,
was
was...
specifically around the
She
Guardianship
wasn't
Act.
competent.
She was non-competent.
So for a competent person, common law precept would be that I'm not required to offer a treatment that is not is futile or is not in the patient's best interest.
Certainly in New South Wales, our guidelines. Lindy, what do you think?
That's right.
For a competent patient.
Well, the person has capacity. Queensland law is a little bit different when there is a lack of capacity and there is an obligation to get consent before you withhold or withdraw treatment, even if it's futile. If the patient is competent, there's no obligation to provide treatment which is regarded as futile. And of course, there is some looseness about when treatment will be futile
Right.
and when it's not, and that's not defined.
Well, that's where the process issue... I mean, what New South Wales Health has done is come up with an algorithm for how to decide what's futile, which is, in other words, it's a process-based definition of futility rather than a, if you do it 100 times type definition, which has never really stood up. Any other comments from the panel about that? And I'll go to Jeff's comment. No. Jeff, what do you
I'm
want
going to answer to some extent your question about intensive care, who gets into intensive care. It's a decision that's made every single day, a couple of times each day. Probably 90% of them are straightforward, maybe 10% are not so straightforward. We've got a system at Royal Brisbane that if there's doubt, you default to treat and often get a second opinion amongst your consultants. But what worries me more, because eventually there's going to be a decision to withdraw or not, or futile therapy or not. Now, we make that regularly in intensive care. Now, I've been in intensive care 30 odd years, working in intensive care. None of those decisions, apart from maybe the first few, were worrying to me afterwards. I've got to learn to live with it. What's more worrying for me is when I default to treat and a month later the patient then dies. In other words, I've prolonged the dying process for a month. That worries me far more than the occasional, maybe, 2 or 3% out of 100 that I get it wrong to withdraw.
Yeah, I mean, a lot of what poses as an ethical dilemma at the end of life is often a factual dilemma about the uncertainty around the decisions that you're making. So it's sometimes very hard to extricate what's truly a moral question from what's actually a practical question of prognosis. And has anybody heard of the Amber Care Bundle here? Have you come across this? We're about to launch this in New South Wales, but in the UK, there's been this thing called the Amber Care Bundle, which is amber because of its this is the orange light. They've got green, amber and red. And what they're trying to deal with is what you do when you don't know, which is, I guess, what Jeff's talking about. There is a default that you then have to try something, but then you have to be monitoring constantly for signs of whether that's getting better or not. We do that routinely in intensive care, but they're trying to broaden that idea to essentially the whole of acute care. Everybody's there as a trial of treatment, not as a definitive treatment, and they're in this amber zone. So have a look at the Amber Care Bundle if you get a chance to have a look at it.
Peter, one of the problems we have at the moment, of course, is that people are much more willing to withhold treatment than to withdraw it once it's started. They still seem to be more willing to withhold it than to withdraw it, from my research. And whereas I think it was Jeff, in fact, who said at one stage that you ask the same questions in both instances. Will this meet our goal of care? If it clearly will, you start it. If it clearly will, you don't. If you're not sure, you start, but you set tight timelines to ask the same questions. Is this meeting our goal of care? If it clearly is, you continue it. If it's clearly not, you withdraw it. If you're still uncertain, you set another tight timeline for asking the same question.
Yeah, so it's setting and resetting goals of care.
So you don't deprive people of a chance of what may potentially be helpful treatment.
Yeah.
But you don't just stick it in and leave it there forevermore, amen.
Did you want to say something?
I just wanted to come back to the first question about prognostication and probability. I mean, it seems to me that that's a generalisable problem across the whole of medical practice, so that if you're talking to someone about, going onto a drug and bringing their cholesterol down or whatever it might be, you have to talk to patients usually in probabilistic terms, and they'll be more or less explicit or definite. I can confidently say that you've got a 95% chance of having your blood pressure controlled or whatever it might be, and then there will be far less clear examples. But I think it's the same here when we're trying to prognosticate for families and so on. There are more or less accurate prognoses that can be made, but that's just the way things are. And so I think that it behoves people in all of those different situations to really focus on the way they communicate to people. And I know that's all good in theory and much harder in practice. But a lot of it, I think, comes down to the necessity to showing people that, well, we just can't be that definite here. And working at the level of how definite you can be in each situation.
Can I then ask the panel, because this came up at the ARBOR meeting as well, what should we do if there's obvious either not just uncertainty but actual disagreement between clinicians? The choices are we just keep that to ourselves, or we disclose that to the family that there's a...
So I'll say something. So palliative care is quiet, as Peter said, but we're a quiet bunch because we're probably soft and caring, but I'm not like that. So I'm not going to sit back and be quiet here. The question you just asked is a really important question, especially when you have terminal patients. So I'm strongly of the belief that if you have differing opinions amongst clinicians and patients are in the last few months of life, then the setting is very different. It's all very well to have differing opinions about high cholesterol, but if we're in that cutting edge of the last 3-6 months of life, then clearly palliative research suggests that bereavement and grief of relatives is very much harsher and difficult if they perceive there are differing opinions. So it behoves all of us as clinicians to ensure that we get around the table and come up with information that is consistent. Because as many of us work in acute hospitals, we would all know examples when there are clearly differing opinions. And when those patients and or families hear those differing opinions, then that's when all the trouble starts, whether that be in ICU, whether it be oncology services or in a palliative setting. To the point that I have reluctantly withheld palliative care services because a clinician will say to me, we don't need palliative care, and they've said that to a patient. So that's happened many times in my career. And I'm happy if all the clinicians agree this person doesn't want palliative care, just in the interests of better care, I'm happy to lose that battle. But I think that last 3 months is a very important time for clinicians to get general consensus.
I do find that families have got antennae. They're very sensitive to that differing opinion.
also playing into that is that across the board, except for palliative care consultants or palliative care health practitioners, doctors overestimate the time that people have remaining. And they also don't tell people that they're dying. You know, I've done 6 months in palliative care, and I do it in emergency department. I tell people, you know, is your cancer curable? Well, the doctor hasn't really told me. And I'll say, oh, I think it's probably not curable. Why do you think your doctor didn't tell you? Well, he just doesn't like to give bad news. And that's the problem. Doctors don't tell people.
So that gets back to Mal's thoughts about communication. The cornerstone of much of what I thought you talked about today comes back to how well do we as a society communicate about death and dying? And that's really bad at the moment. Because there is this symbolism that you alluded to in the first question. I've got to say I alluded to it as well, and I'll pick you up on it, because I like to pick people up on it, is that you talked about losing the fight. And the symbolism in our society is we fight illness at all costs. And so for you to talk about death and dying is totally the anti-culture of current medicine, current culture. So the communication we need as a society is to talk about when you get a terminal illness, this isn't about a fight. This is about how do you want to live best with that cancer. How do you want to live well with treatment or without treatment? How do you want to spend the last days of your life? Do you want to spend it in ICU and in an emergency department many times? Or do you want to go down to the Gold Coast and rent out a holiday apartment and be with your family for a few weeks? That's the discussion that we're not having in our society. And that's the communication we need as a society. And then the other communication is how do we teach nurses, doctors mainly, how to communicate better about end-of-life care, how we open up discussions about prognosis many months in advance. And so the question, Peter, you alluded to, I teach a lot of the junior staff now is have a think about, could this person die in the next 12 months? And if the answer is yes, then that should be the prompt that we start talking about all these things. And then hopefully you won't get the emergency admissions, you won't get the ICU admissions, you won't get doctors debating what's good or bad for people because patients and families have thought.
And when, Mark, you said the person doesn't want palliative care, who's telling you that? The other clinicians are telling you that. What does the person know about palliative care?
Because palliative care is the greatest myth of all time. I mean,
because people think that it means...
As I said at a conference last week, Colleen, palliative care is just good care.
Yes.
Yes.
It is just good care, and if society talked about death and dying a bit more, they would see it in those terms.
But a recent example here in Queensland, my sister in September died in Southport Hospital, 10 days from diagnosis to death from acute onset leukemia. Being my sister, you won't be surprised that she had her advance directive and her substitute decision-maker doctor,
I'd have been shocked if she hadn't, Colleen.
which were presented by her daughter on admission, were scanned straight into her file. A doctor came the next day and said, I notice you have an advance directive. My sister said, yes, I do. I notice you've said you don't want CPR if your heart stops. No, I don't, because we discussed all of that as well. And she said, we will respect your decisions and all your other decisions in the document. I spoke to her and talked about palliative care and went out to the desk and said to the nurse, how do we organise a palliative care consultation for my sister? And she said, I know the treating team organises that. I said, how do we get the treating team to organise a palliative care consultation for my sister? And she went, I'll make sure they do. And a palliative care consultation by a palliative care specialist occurred the next day. You've got to fight for it. You've got to demand it. Palliative care is not, I mean, you know, the treating team will organise it. Well, they wouldn't have if we hadn't insisted.
Yes, your comment.
As a GP, I'd like to offer a few comments. Peter, your talk was certainly very thought-stimulating. But I think one of your comments underlying one of the problems that I see, you mentioned the joint decision-making, you mentioned hospital clinicians, palliative care in the hospital, ICU, patient, you left out the GP. And this is a major problem that I see, not just in palliative care, but many areas of medicine. As a GP, I travel with my patients through life. Many patients I've had for many, many years. I know them a lot better than you ever will. And they trust me, usually, a lot better than they may trust hospital people that they don't know. When it comes to conflict between clinicians, one of the ways that could be resolved would be to call in the family GP. Now, not all GPs want to do that. Not all GPs know the patient well, because patients do tend to move around. But I want to open minds up to the fact that GPs are available. They can even do a phone case conference. I personally would be more than happy to come in and sit around a table, because I think one of the most important things that I can do for my patients is to help them to die with dignity and pain-free and to have a good death. And yet, like me, I am denied that often simply because they go to hospital, as you know, they get snaffled up by hospital, they give them false hope often by the oncologist that they're going to cure them, and by the time that the oncologists realise they can't cure them, when they do call in palliative care, sometimes it's often too late for me to be involved. One concrete example, a patient who was actually not a patient, but the husband of a patient, who I was asked to take over the care, was in hospital dying, probably had a week or two to go. The hospital phoned me asking, would I take this patient on? Yep. The next I heard, the patient's wife came in as my patient, and I said, when's your husband coming out? She said, he was discharged a few days ago. I knew nothing about this, had no information. Because he was discharged badly, he was in pain, he had to go back into hospital, and he won't get out. And yet, simple communication from the hospital teams to GPs will help to minimise that happening. So my request, my plea was, is that everybody involved in this should always consider primary care, and not necessarily just the GP, but some of the community nurses are also very much involved in this and know the patients.
Thank you very much for that. I think we have to applaud that. No.
Thanks, Lynn. I agree completely with that, as you might expect, and it sort of goes to Peter's link analogy. But I'm not sure what the proportion of GPs remains who are willing and able to act in the way that you're talking about. You know, you and I are sort of EOPL, end of professional life.
I'll borrow that.
And so, you know, you probably still do house calls, but, you know, how many people do house calls? Not very many anymore. And so I think, I appreciate what you say, and I agree wholeheartedly with it, but in practice I'm not quite sure the proportion, the extent to which that's going to work. I'm not trying to sort of put a dampener on the idea. It's a great idea.
I think you'd be surprised, Mel. A lot of my work is in interfacing with aged care facility residents who come to the hospital, and if they come to the Royal Brisbane, a lot of them we will admit for 24 hours to our short stay ward. We have a healthcare nurse practitioner who will visit them in the facility, but a caveat around that is that they must communicate with the general practitioner. And similarly, if we're going to make a change and send them back to the facility, we must communicate with the general practitioner. When we started doing this, people said, look, the GPs aren't interested, they're too busy. They are universally interested, they know those patients in the aged care facilities, they would like to be called and they've got great insight. And they have to be the one responsible once we discharge them from the hospital. But I think the layer of nurse practitioner that's coming in, I think will add a perspective to the end-of-life care. I try and tell my junior doctors that doctors care about the patients, nurses care for the patients. Nurses are much more likely to be able to tell you whether something is futile or not. I mean, I think Professor Lippman's ICU nurses are probably days before his consultants decide that this is a waste of time. They know, and those family members know. The nurses know because they care for the patients, which is quite different to caring about the patients, which is what we do.
And that's the other major grouping. I mean, general practitioners, but nurses are not being given enough airtime on this question as well, because I think that comment's absolutely right. We've worked with general practice. We get this critique all the time. The New South Wales Health Department writes something, goes out to the College of GPs, they say, you haven't recognised that GPs are the main people. And the problem with that is that the Health Department doesn't have control or access to GPs in any meaningful way. So it's extremely hard to work with the GPs as a group. We had these divisions of general practice that got all smashed and they've been replaced with Medicare locals. Has that happened here as well as a national project. So everything's just been all rearranged again. All the people I used to talk to, I can't talk to anymore. So I think there are major methodological problems with how we work with the GPs, but I couldn't agree with you more. The sleeping giant of all this lot, the absolute beating heart, is the GPs, and the UK have tapped into this in a major way. The UK is the best place on earth to die. I think in no small measure that's due to the fact the GPs have taken responsibility. And I'd love to see something like that happen here.
Perhaps it might be just a little bit helpful to know that the RACGP and two of their working parties are really embracing the concept of advanced care planning and education for GPs around advanced care planning. And I think the most recent shift there of the 800,000 grants that recently happened, as you would know, to get the documents into the personally controlled electronic health record will be one of the links in that chain between the GP and getting them into the record and the record going to the hospital. I think you said earlier that you hardly ever saw any, and I think that the people that I work with who are completing them are not dying yet. Seriously, I think the ones who are doing it are the younger, older people.
The younger, older people.
Yeah, because the older people are used to yes doctor, no doctor.
Yeah. Right.
Watch out
It's
for
we
the
baby boomers. Yay, go the boomers.
Anybody else tell them what to do.
Yet again, we dominate the field. Other comments? Jeff again. Oh, sorry.
You pointed out that the Geelong data that someone has aspiration pneumonia, they want X, kids want X, and the substitute decision maker often doesn't do the right thing. Research has shown that when you enter a patient, exactly the same thing happens because the surrogate decision maker doesn't know what the family want. How do you get around that?
Well, that was. I mean, again, this would be great to explode that whole question. But I think having to make a substitute decision is the very last resort in what should be a chain of possible supporting events, of which advanced care directives and stuff have to be part. In other words, you have to flesh out what it is you think that patient would have wanted. And as you know, in ICU, frequently the solution to the entire dilemma is to say, what do you think he would have wanted? And if you can keep bringing it back to the patient, all of a sudden everything defervesces and he's, well, actually he wouldn't have wanted it, and you go, well, let's work on that basis rather than anything else. So I do think that there's hope that we can proceed in that sort of way. Any comments from you guys?
I do two things with families. One is if you put yourself back 5 years, if you could have your granddad back 5 years ago, what would he be saying now if he was sitting in the chair next to you?
Yes.
Not, this isn't what, I don't want to know what you want to happen, I want to know what he would have wanted to happen. And the second thing, when the family says we want everything done, I say, stop, look slightly shocked, and I say, of course, we always do everything. We always do everything that is in the best interest of your family member. We're not going to do things that are futile, painful, undignified and unlikely to work. And then most of the time they say, yeah, that's what we meant. We didn't mean CPR.
Yes.
Yeah. And
Yes.
Peter, one of my palliative care colleagues, she says to patients, she never, ever asks, do you want us to do everything? Some of the young registrars might come out and ask that question and get dragged off the floor quickly. It's the wrong question at the wrong time. What she says is, to someone who is perhaps in denial, I understand that you're grieving and you don't want your mum to die, but she is going to die. What I need you to help me understand, if they're asking for all these treatments, is why do you want us to prolong her dying? And they say, oh no, we don't want you to prolong her dying, but that's what we'd be doing if we gave her those things you're asking. We're not prolonging her life, we're prolonging her dying. And that's what I keep telling nurses and others, change your language. Talk about, we don't want to prolong their dying, because you're not prolonging their life.
Yeah, and my only comment about that is, we would improve our own communication skills around this if we felt a little bit more comfortable about the inevitable fate that we all face as well. Yeah, you had a comment.
In defence of the general practitioners, it takes a long time to fill out an advance health directive for anybody, and they have to say that I'm competent, which my GP did. But then having signed it, there is no way that I can ensure, or that one can ensure, that that will be taken note of, other than telling family where it is. There's no registration or no way that we can say, I have an advance health directive. And I'm wondering if there's any solution to that.
I've got a few for you, Glenda.
Well, they are looking at that in Tasmania, actually, looking at registering them. They're doing it in Spain. So, I mean, it's a possibility that we should register them. What are they?
I'll give you the joke one first, Glenda, about the nurse who had not for resuscitation tattooed on her chest, and they tell me that on her back she had PTO.
I know that nurse.
You know that nurse? Okay. I actually have someone I know who has her advance directive documents, all of her advanced care planning documents, on a flash drive, on a chain around her neck, on a USB stick, and it's engraved ICE, just like ICE in your phone. Neither of them are good ideas. A lot of the older people I work with, I give them a card, and on one side it says, I have written an advance directive, here's where you can find a copy. On the flip side, I have appointed an enduring guardian, which is the term in New South Wales, enduring power of attorney for health matters in Queensland. Laminate it and stick it in their wallets. But the personally controlled electronic health records, which are starting finally to be used, which will be completed by GPs, which are going to be able to have the documents themselves uploaded into that record, and that can travel between doctors and hospitals and everything else. To my mind, it's the technology that's going to help us solve this difficulty.
I'm on a national committee looking at how the patient-controlled section of that medical record might be a way of the patients having a voice. One of the things I'd love to see is a sort of conversation where the patients can actually write something and that somebody will read that and potentially even respond to it. I don't know. I mean, maybe I'm just daydreaming here, but the patient-controlled section of the electronic medical record is a very interesting area. They've very interesting bit of real estate, and we're not quite sure what to do with it yet, but this could be one of the uses for it. Yeah, sorry. Sarah.
I'd say one of the overlooked uses of the Advanced Health Directive is that it can point to other family members, adult siblings, about what the person wanted when they're in conflict. So I'm one of 4. I have a brother in Northern Territory, I have a brother in WA, I have a sister in Tasmania. Muggins is here with father, who's just done his Advanced Health Directive. So that was a discussion between all of us that we all have, so that at least the family's on the same page, because as many clinicians in the area will say they dread that brother flying over from WA where he manages a mine and everybody jumps at what he says. They dread him coming in through the door. So there's that, at least as a side thing of promoting it for people to do, is about this is what mum or dad wanted and this is what we know as siblings that we can agree on.
Yeah, I always say you really need one of these if you've got no children. You need one even more if you've got 5. Yeah. Yeah.
Just as a social worker in a hospital intensive care unit, I think sometimes we live in the grey between the doctors and the families and the nurses. And I think communication is the key. I feel that there's often a fear of using the word, like you're saying, they're dying. You know, the language is about the communication. There shouldn't be a fear, which there is, about whether the brother's flying from Perth. I experienced it today, you know, in a family meeting. But really it's about that confidence of the doctors to feel confident. You've got all the training. You know, like it's the confidence in your own training and your own abilities as professionals, instead of fearing the family. It's asking them, what do you think? I mean, what do they know? You know, they might work in Coles and they'll go, I don't know, you're the professional.
Yeah.
So it is that confidence in your own communication.
Yeah, and communication has a number of levels of meaning here. It's communication in the sense of the GPs being communicated with, but it's also exactly how you speak and to whom and in what way and what you say. And I mean, the oncologists come out very badly in most measures, including Lindy's work on knowledge of law. They were the bottom law at end of life. And when it comes to this fake prognoses, they're spectacular. The only literature I know on that, they overestimate survival by 5-fold what the reality is, which is really spectacular. Actually, sadly, intensivists systematically underestimate survival as well. So between us, we probably should just split the difference and we probably get somewhere close to right. But one thing they have done is that they have looked at communication. The oncologists have looked at communication. You may have seen their onco talk You can get it as an app for your iPhone instantly. You can download for $1.99 Vital Talk, which teaches you how to communicate with people about end of life. If you can be bothered watching an American squawking away on your iPhone, I personally can't. I don't know what you think of that communication skills training and stuff.
Untitled Talk I know well, because Untitled Talk taught many palliative physicians in Australia. It's a group of very highly skilled communication oncologists and palliative care physicians from the US, so by all means look it up. But I don't think many oncologists in Australia have been trained by Untitled Talk. Just to concur with that question, I was surprised that your audit only showed 20% didn't have the word dying in the chart. I'd actually say in my experience in acute hospitals it's 100%. We live in a very medicalised world. Make no mistake, if I ask clinicians in my hospital what's happening to patients in the last week of life, they will give me every medical term under the sun, but they won't use the word dying. They will tell me they're hypocalcemic, they're hyponatremic, that their blood counts are such and such. They'll tell me their oxygen sats to the point of the death of that person. I had someone today having oxygen sats done as they took their last breath. That is the world. That is the world we live in. We should make no mistake. I told you I'd talk about it.
Yeah.
We should not delude ourselves. This is a highly medicalised system that doesn't want to talk about dying. Peter is talking about dying as a topic, but that is not a topic that enters an acute hospital. It is about how to save people, and it is about how to save and battle illness. That's the symbolism that is out there. That's why palliative care doesn't have a ward in acute hospitals. That's why the two biggest hospitals in Queensland don't have a palliative care ward. That's why to fund every dying person in the Metro South District of Brisbane costs the same as one dose of chemo. Okay? That's the sort of disparity you've got. So when you say palliative care hasn't taken up the challenge, politicians haven't taken up the challenge.
Yes.
My medical professional colleagues haven't taken up the challenge because no one wants to talk about dying. And so your GPs, like the beautiful GP up the back, is a lone voice. Because what generally happens is acute hospitals foster an image of let's go to the acute hospital and get that high-tech intervention to save you one more time. Let's not live on the beach at Gold Coast and have palliative care look after you.
I'm going for the Gold Coast.
To you all, palliative care is not about specialist palliative care. Palliative care is a philosophy that all clinicians can embrace. ICU, you don't, as some of my patients say to me, where's this palliative care place? It's no place, it's just everywhere.
It's a place in the heart.
But saying that, to die well at home and to reverse the trend of dying in hospital, we as a society need to realistically fund the ability to die at home. And for GPs to do home visits, they also need domiciliaries paid to go in every day. They need equipment to allow people to have hospital beds at home. They need home oxygen if they need home oxygen. They need medications at disposal. They need palliative care nurses, like some in the room, who are on call 24 hours a day. And that does cost money, but I can tell it's a lot less than intensive care.
Hospital, yeah.
Absolutely, and that's the economic argument. Sorry, you and then Jenny. Yeah.
I actually think it's more fundamental than not talking about dying. I actually think it's not talking about the emotional dimensions of working in healthcare. The reason we don't have these discussions is because partly we're omnipotent, we like to think we can fix things, but also because it resonates with our personal vulnerability. It makes us afraid. We think it could be us. This is really scary. We get immersed in suffering, we get immersed in grief and pain, and no one talks about it. Many years ago, I'd seen a woman who was dying. She had 14-year-old children, twins, and I'd gone into the nurse's station to make a note. It was sort of obscured from public view. And as I wrote my notes, I had a little quiet week. And an intern came in and said to me, "Doctor, you shouldn't be doing this work if it upsets you this much." And I said, well, when it stops upsetting me,
then I'll give up.
Stop doing it. And I think we really need to have a talk around learning to tolerate the fact that we're in work that's wonderful and exciting and thrilling, but it's hard and it's grievous, and we need to tolerate our own pain.
Yay! Wow. Just because I have to say this, and Jenny knows, I tried to give a talk about almost exactly that at the ARBL meeting. I don't know how anybody related to it, but I was actually talking about introducing mindfulness-based stress reduction as being a standard piece of our own armamentarium, a settling thing for all of us. Now there was a comment. Sorry, yeah, was it you?
Being one of the older ones, I have to agree. Two of the best things I ever did was the palliative care course in the old Mount Olivet here. That was one part. The other part was I'm old enough to have sent the first patient and been involved in Karuna, which was people dying at home.
Oh yeah.
And I visited home as a specialist, and I did that. I did the palliative care bit. It's only when doctors are prepared to do those long hours, to actually walk the journey, that they then face their own mortality. I now teach Zen. I know John Cabot's Zen.
Oh yeah, right. Yeah, that's what I've been quoting.
I came out of a Zen retreat tonight, and the purpose of Zen is to face the question of life and death.
Yeah.
And until every person comes to face the question of life and death for themselves, they can't lead another. They don't know the spot. And unless they know the spot, they can't do it. People in palliative care do it. Every doctor should do a term in palliative care. That's the only way. It's education and being immersed in it. Because as doctors, the tradition of doctors was that we walk with the dying as well as the living.
Yes.
And we've lost that.
Yes. I wondered if comments on that.
Agree with all of that, and Jane's comment's very real. Just to give you a stark example, most of you may or may not know, but most palliative services have professional supervision and debriefing as almost a compulsory part of our service. When registrars come through, training registrars come through our service and they hear that we're going to have supervision, they have no idea what that means. And so when Jane says, how do we emotionally cope with death and dying, if services like oncology, and oncology trainees at the moment in America, I don't know if you've heard the figures, but oncology trainees in America are burning out at the rate of about 30% in the first 3 to 4 years. It is an incredibly arduous thing to do oncology these days. And they have no supervision, they have no debriefing, they don't talk about death and dying, and yet they're seeing cancer patient after cancer patient, and the focus is treat, treat, treat.
Yeah, I think intensive care, we have 250 deaths a year. We've never even talked about any of them, other than could we have done better? Just hardly debriefing.
There are M&M meetings, as they're called, and they're not the eating variety M&Ms. They're mortality morbidity. They are actually a joke, aren't they?
Yes.
They don't actually talk about...
Eating M&Ms would be more useful, I think.
All they are an important tool about whether people did the right thing, which is usually the right thing about what tests we did. They really don't allow people to express what their sense of that death was about. And that's,
sorry, comment over that. Oh, sorry, Jenny, I was going to ask you next. Yeah, go if you like.
I've just got a few comments about a few things. Back to Mark's comment about dying in the home. We've got, and Sarah and I spoke about this, an increasing demographic of single-person households in our society. And I have a big fear, like as Mark says, we've got to recognise the cost involved in care in the home, and that's entrenched in the female caregiving role for free, and that it'll come back and the expectation, and it's a cost saving. It will be a cost saving. Your comments, Peter, about the consumer, I think we're in a consumer-driven society, and I think part of our lack of speaking about death and dying is driven by society because, really sadly, we can't sell stuff.
No, it's the end of consumption. There's something for a headstone. He can no longer consume.
My pet area is vulnerability, and leads to something Sarah and I are planning, and I don't know how many of you have heard of death cafes. It's actually
meeting place, people
an idea, a program that started, I think, in the States, and I've seen they're in lots of places in the States. They've started in Australia as well. They've been at Byron Bay, and Sarah and I are just in the very initial stages of planning a death cafe, and I think that this is the opportunity to talk about our own vulnerability as healthcare workers, and that's, I can't agree more. We've got to recognise that all human beings are vulnerable, and in a medicalised world, that sense of vulnerability has been reduced to the place that it's masked.
It's a fantastic project.
The Death Cafe is really about improving health literacy for all Australians. So there may be some health workers who come, but it's generally Australians an opportunity to talk about death. So it'll be very interesting when we run the first one. I've got no idea who's going to come, or even if the cafe will let us run advertise it, because who knows, no one may never come to that nursery again. So I'd be really interested to see just how it goes over, whether it takes off. And, you know, my thought is we'll have lots of, I'm wondering if it'll be filled up with clinicians who say, we need this, we need that, or it'll be many general Australians who come along and just say, you know, it's time to talk about death and dying in an open way before, you know, we're on the cusp of it.
That's a great idea. I'd like to be the barista at the Death Cafe. That would be a career choice of some note. So there's a comment over there and then over there, and that might be as much as we've got time for, I think. Yeah.
I'm enjoying tonight, so it's great to have this dynamic conversation. I'm always interested in that prognostication aspect, or when you start to bring up this conversation about someone's end of life. And I take on board that sitting across from someone, do you think this person will be alive in 6 or 12 months' time? Is that when you should start the conversation? Because I've seen that, and I think that is very useful in itself. And I know there are blood tests around as well that can show, you know, you've got certain blood tests that will indicate that death is likely within a few months, so that's when the discussion could be had. I just wanted to share an experience I had when I did some research about heart failure and working with cardiac teams. And for me, I could pick when someone was going to die when I ordered the progress notes. It was always 2 or 3 pages after the progress notes when I saw that a dietitian had come along and had wrote 2 full pages on how this person should now eat. So that for me was a very interesting insight, and without fail, it was not part of the research. It was just an interesting observation that I just picked up myself.
Yeah.
I thought, wow. But there was no conversation after those 2 pages of the dietitian when death occurred. There's no word of dying. It was a code happened. They went into ICU, and then they coded again. Then the discussion was turning off ventilators. Nothing about death still. It was just turning off things.
Yeah, I mean, this is like diagnosing dying, which I think palliative care specialists are particularly good at, and they have scales, you know, like Karnofsky and stuff. But I do think there are general tools out there that all clinicians should be using. I mean, if you go to the Gold Standards Framework website and look at their prognostic indicator guidance, clues like what you're talking about are there everywhere. Do they spend more than half their time in bed? That's all you need to know that you've got somebody who's almost entered the dying process. So the fact that we aren't teaching this widely is shameful and basically scandalous, because dying can't be everybody's business, and everybody starts looking for it and recognising it when they're seeing it.
Patients want to know. Every day I am asked, how long have I got?
Every
day. And then when I say, well, palliative care teaches to say you've got short days, long days, short weeks, long weeks, short months or long months, or maybe years. But patients really want to know, and you've always got to say, I'll never be right, and I'll give them spectacular examples. When I was an intern, I told the family that they were going to die in the next hour, and 3 days later, they're all still there. Patients really, really want to know.
Yeah, and should know, because that's what gives them access to the choices that they can make.
Doctors are terrified of causing harm by telling them.
I know.
But every day I have a patient say to me, thank you, you're the first person to be honest with me.
Yes, and I haven't witnessed a single complaint where somebody was honest with people. That hasn't been the source of complaint.
Sorry.
One person did try to hit me.
Okay, one.
Just a little term that might be useful to people. A lot of families cannot get through their heads, and a lot of times they're not told that stopping eating and drinking is a normal part of the dying process. And they keep wanting you to try to force them to eat, or they try to force them to eat. And there's a beautiful term that's used in Europe, which is putting down the spoon as an indicator that death is approaching. And it's very gentle, isn't it? Putting down the spoon.
The Italians say, my Italian grandmother, my mother-in-law says, when you look at the wall, if you're in the hospital and they turn and they look at the wall,
Yes.
they turn away.
It's like Shirley Valentine. You get the last word, I think.
I just actually had a question. I'm from a medical background. I just wondered if somebody presents and it's an end-of-life situation, and they don't have a next of kin or anyone close by, what actually happens? How is the decision made? Who becomes responsible for that person? There's a lot of people, especially in my parents' aged care facility, that don't have family, don't have friends visit, essentially don't have anyone. It's very sad. But once the retirement village calls the ambulance and they're taken away from the retirement village, their duty of care ends. The hospital begins. What happens?
This happens to me all the time.
Yes. I give you a New South Wales answer, which everybody develops acute angina and runs for the nearest doorway. Because we're all terrified of it, because the guardianship provisions in New South Wales are extraordinarily draconian. You know, we have to promote and maintain health and well-being. We're not allowed to let people die. But
it's a really interesting question. I mean, the question is, what do you want us to do? Do you want us to do what we would have done for ourselves? And I ask meetings all the time. Who here, when they've got a nappy on and they've got pressure sores and they cannot talk to their family and they are bedbound, wants an antibiotic when they get a pneumonia? Because you will. And none of the doctors put their hands up. All right, who here has given a person in that setting an antibiotic in the last week? And they all put their hands up. We don't do for our patients what we want. There's some good research in America showing that American doctors die with fewer interventions.
Which means we're all fabulous hypocrites, which is a rather daunting proposition, but I think probably true.
One of the things that you raised there is something we've all got to be working very hard towards. Why did they go in the ambulance from the rest care facility to the hospital?
In the first place.
They were in their home. If the dying was foreseen, and it should have been, then preparations could have been made. I have had the people say, oh, because we can't get the GP to come. If you've got your planning done in advance, you don't need the GP to come. Unless the person has a fracture or something that absolutely means they have to go to hospital. Even with family, even if they have got someone, if you get your plans done and you say, if this happens, do you want us to keep them comfortable here in the facility, or do you want them to go to hospital? But if you point out, if they go to hospital, this is the likely things that will happen. The majority of the people I work with say, keep them comfortable here. And if you've got your script from your GP in your file anyway ready, so that you can keep the person comfortable, we shouldn't be sending the majority of people from res care to intensive care or emergencies.
Absolutely true. Look, we could probably go on all night, but I know we shouldn't. And I'd like to, obviously, on your behalf, thank the panel for